So the main topic today, we'll talk about pediatric fever. So technically our topic is a child present with fever and how you would get the history from that patient. So thank you for anyone who complete the pre-assignment. I feel like that would help significantly for you to during this lecture, because I deliberately did not go through a lot of the material that already been reviewed in the video. It's mostly going to focus on the history checking part and not much of the medicine part. All right. So what is fever? If anyone want to shout out for me, what you guys remember from the video, what was the definition of fever that was given in that video? Come on, guys.
Yes, the fever, which means the body temperature is the more than just 37.5 secret serious, or rather 100 more than 100 point 7.8 F. That's all that.
Yes. Perfect. Thank you for answering the question. So it actually it's always tricky when it comes down to talking about definitions of fever, because technically you need to actually define where you are measuring the temperature before you can give an actual definition for it. So the chart on the left that you are seeing is the normal temperature for different age group with different method of measurement. But in general, I think most people in the pediatric world would go with the definition of fever if your body temperature is above 38 degrees or above 100.4. So that is generally what we use. So the way you say this is 38 degrees Celsius or 38 degrees Fahrenheit. 100.4 degrees Fahrenheit, sorry about that. So that's how you would say those terms. So in Vietnam and most of the European country, we would use Celsius. In America, we use Fahrenheit. So I include the number there just in case that if you talk to an American, they might give you that number. All right. So talking about asking history about fever is a little tricky, because usually the framework we give you guys were on card, right? That is for most of the symptoms where you would ask the history, but it doesn't fit very well with fever. If you kind of think through about that, like if you try to go through own card, like onset, yeah, that might work. Locations, that kind of tricky, right? It's body temperature. Durations of fever is also not sometimes might not be very indicative, and so on, like associated symptom, aggravating, other things. So it doesn't work very well. So I create a different one that I use specifically for fever and in pediatric populations, because that's where I practice mostly. So it's called most dear. It's not the most grammatically correct, but it worked for my mnemonic. So most is where you get the characteristic of the fever itself. So most stand for method, onset, symptoms, and treatment. And then we'll go through all of them in detail in a little bit. And dear for me is my triage questions. This is for a pediatric patients. The most important thing that you need to get from the history is how sick the child is and how soon you need to intervene. So these usually the couple of questions that I use to kind of get those informations for me. So I usually ask about their drinking, their eating, their activity level, and risk factor or red flag. So we'll go through all of those today. So first is method. So as I was mentioning earlier, the body temperature varies depending on where you're taking the temperatures from. And that's why it's kind of important for you to know where the temperature is taken. It might change your approach a little bit. So on the slide here are the common method of measuring temperature. I arrange it from the least reliable to the most reliable. Anyone know what tactile means? I think this is one word that wasn't included in the video. So anyone want to give it a shot? You know what tactile temperature means? All right, so tactile temperature
noise.
is
It's noise, nose, sorry, nose, maybe, or maybe hand.
Sorry, I didn't catch that. Can you repeat that?
I think tactile is mean hand, and maybe in the mouth.
Yeah.
Yeah.
Yeah. You kind of a little choppy. What I hear is sometimes related to the hand. I think the meaning is correct from what I understanding. So tactile means touching. So tactile temperature means that the patient is warm to the touch, but there's no actual measurement was taken. So, and that's a lot of times, it's like a lot of mom will come into you in the clinic and say, my child feel warm. That's what we would say a tactile fever. It means that the baby feel warm to the touch, but there was no real temperature taken. All right. Temporal measurement is used in infrared across the forehead to measure the temperature. Tympanic is through the ear canal. Axillary is under the armpit. Oral is a sublingual measurement, and then rectal. So rectal is the most correct, most close to the core temperature, and is a recommended measurement method for premature infant. However, there are one group of patients that we should never measure rectal temperature. Anyone know which group it is? This is a bonus question. All right, I'm just going to answer this one because this might be a little tricky for you to know. So any patients that is neutropenic, it means that if their neutrophil counts is less than 1,000, they should never have their temperature taken rectally because that actually might introduce the bacteria into their bloodstream and cause issues. So that is the one group that is contraindicated. All right. So how long is too long to have a fever? What is the I still remember, like when I was growing up in Vietnam, there usually a saying like that public health video talking about fever. So what usually consider a concerning fever? How long is that in Vietnam? Ready? I'm gonna just start calling people just to make sure things is a little bit more interactive. Let's see. Number 68. Oh, I saw someone raise their hand. I'll take that first then. Whoever just raise your hand, feel free to unmute and talk. You don't have to raise your hand. Just unmute and talk.
As what I observed in the ER, most of my patients with the too long fever are about more than 3 days.
Yeah. Perfect. Yep. Yeah. That's what I used to remember too. So in Vietnam, it's like if you have a fever more than 3 days, you need to go seek medical attention because in Vietnam the prevalence of dengue fever is so high that after 3 days, you probably should be screened for dengue fever. However, in the United States, the risk for dengue fever is significantly lower. So we tend to tolerate a little bit longer fever in the United States, given the fact that the kid is otherwise doing okay. But in general, if you have a patient who have fever for 5 consecutive days, it is concerning, and that definitely need to seek attention, medical attention. Again, the kid is otherwise active, looking well. There's no other concerning side beside the fever. Then 5 consecutive days is concerning and need to be seen by a physician. And then any fever for 8 consecutive days without a source is what we classify as fever of unknown origin. And this is a very, very big topic in pediatric, and it can take an hour to talk about. So I'll let, we're not just gonna go through it today. I'll let those who ever interested in it can do some research later on their own. So the next part in our mnemonic is T, so for treatment. So this is the question that I want to know when we ask about treatment: what, when, and how much. So what is why, like, what did they use, what medication, what method they use to try to treat the fever? The most common thing that we use in America is antibiotics. I know in Vietnam we have other things like using cooling water, all of that, but in general, evidence have not really been supportive of those. So the most effective one is right now still antibiotics. And these are the 2 common medications that are used in the United States. So ibuprofen and acetaminophen. I include the brand name here just because that most of American patients probably would know the medication by the brand name and not the generic name. So you will hear Advil or Motrin and Tylenol a lot. So Tylenol is pretty much the same medication as paracetamol, so Panadol that we use in Vietnam. And aspirin is another NSAID, but you should never use it for antibiotic reason, especially in pediatric populations, because it's associated with Reye syndrome, and it's a devastating disease. And even though it's very rare, we don't want to risk it. So never give aspirin to pediatric patients. There are very few specific conditions that we use aspirin for in pediatric, not for fever. All right. When? So this is important because it kind of help you to kind of know which way you can do next. A lot of times you will see these patients in the clinic when they actively have a fever, and it's good to know when was the last time the medication was given so that you can give them extra dose of medication depending on how soon it was from the last dose. So I always kind of love to know those informations. And the last question is how much? So it's a little bit different in pediatric. Every medication in pediatric dosing is weight-based. And a lot of time, the reason why the patient doesn't respond to medications is because they was underdosed. In United States, there are most of these medication in liquid form, and they actually give patient a syringe that have like pre-measure dosage on the syringe. So like they would say if they will have life for like 2 kilos, 4 kilo, 5 kilo, etc., so that patient can measure. Even with that, I would say 50% of patients showed up in the clinic or in the ED. When I talk about dosing with them, most of them were underdosed. So it's important to making sure that you review the dosing with parents. And the other part is also very dangerous is overdosing, especially for Tylenol, because it can cause liver damage. All right, and then we'll talk about the triage questions. So this is kind of the part where I decide whether the kid is good enough to stay with parents, to go home, or there need to be an escalations of care. So the most common complications of fever in pediatric is dehydrations. Because when you have a high fever, your insensible loss significantly increased, and also the body usually not feeling very well. And the first thing that the baby reacts to not feeling well is to stop drinking and stop eating. So they are at very high risk of develop dehydration. So I always making sure that I talk with parents about their drinking level at the moment. So usually for like babies who still breastfeeding or bottle feeding, I would ask them like, how much are they taking by the bottle? Have they been finishing all of their regular bottle, or they've been kind of like not finishing them? When was the last time they was able to take the full bottle? And especially for those who still are not toilet trained, I talk about how many wet diapers that the baby has been having, because that is a good way to kind of judge the risk for dehydration. If you have a baby who have not had any wet diapers for more than 8 hours, that is a very concerning sign for dehydration. And I also sometimes ask about how heavy the wet diapers is, because a lot of time parents will stick to a routine and they change diapers every 3 hours. So when you ask them how many wet diapers the kids have, they will say 8, but then you turn out it's like half of them was dry. So it's also kind of like good to know like whether or not the diaper is still kind of heavy, like the regular, or is significantly less heavy. So those are the important questions to kind of drive on when you talk about drinking. And then eating, it's good to assess for nutritional status, making sure that the kid is still doing well with that. As I was saying, when children are not feeling well, they tend to stop eating. So we want to making sure that is maintained. And also, a lot of time children cannot really tell you that they are nauseous. It's just a really unusual feeling for them to describe. So a lot of time they don't know how to say it. But if you have a child who's not really wanting to eat, it might be because they have nausea. So that is also kind of a good way to kind of pick that information up. And last one is the activity level. This is very important. A healthy child is a playful child, and if you have a child who's normally bouncing off the wall and now just laying in bed not wanting to move, that is not a good sign. That is a sign that things not going well. So it's kind of where you kind of deciding whether or not the kid have some like picked up a disease, but it's recovering, or the disease getting worse and he might actually go into shock. So this is where the mental status come in. He's alert, he's awake, he's interactive, or he's sleepy all the time, he's very lethargic, etc., etc. All right, and then the last part is risk factor. So this is one of the key point when you talk about getting a history from a pediatric patient, because this will change the way you manage patients significantly. And we'll talk about that in a little bit as well. But the couple of like point that I try to get in my history is the birth and developmental history. So if there is any significant birth history, one of the most important one is whether or not the child was born prematurely, because premature infants have higher risk for like develop infections and more severe infections. If the child have any history of developmental delays, because that might affect how you assess the mental status, the playful, the activity level, because if they are delayed, then you might need to assess them a little bit different. The medical history, any major thing that can increase the risk for severe infections, so congenital heart disease, asthma, diabetes, or any kind of like cancer diagnosis history, all of that. Immunization status is an absolute need for every single patient's pediatric patient with fever. You need to ask these questions because that will change your management 100%. It's always good to know any kind of sick contact that the patient have had, and daycare attendance. So the reason I ask about those usually because they're like, if anyone who have kids in daycare probably know they are like a petri dish over there. They probably bring home 5,000 different virus every few weeks. So it's kind of good to know what kind of bugs is happening at daycare. And attending daycare is increase the risk of picking up infections, generally viral though, thankfully. And last one is more relevant for teenagers. So usually those age group are have more high risk behavior, and it's important to assess their sexual activity. All right. So if you guys look at the mnemonic that I just mentioned, I deliberately skipped the symptom part and I mentioned it at the end. Because so a lot of time patient will come in telling you a few symptoms, right? So a lot of time they say, my child have fever and a cough, my child have fever and a running nose. But in pediatric population, sometimes it's very hard to get those symptoms from your patient. They are not an adult, right? They usually don't know their symptom very well. So it's really hard to get the information from them. And what if your patient is a 3-day-old baby? They're not going to be able to tell you any kind of symptom they have. The only thing that the parent probably going to bring the kid to you is that my kid have a fever, right? So a lot of time when you ask those kind of questions, this is what you're going to get. I don't know. So for us, when we get pediatric history, we rely a lot on what we call a review of system, which is a normal part of a history in every populations, but it's especially important for pediatric patients. This is a chance for you to kind of run through head to toes, making sure you rule out all of the things that is concerning, that might help you to kind of triage your patients a little bit better, and kind of point you to a direction. So this is the list of common questions that I will ask. It might get like more targeted or have some specific questions depending on how the patient present and how the patient answer these questions. But this is kind of generally would cover a lot of the topics that like a lot of common diseases that you will see in pediatric populations. So for general, always ask about the activity level, the color of the patients is very important. Are they very red, or are they like very pale compared to other child, or they are like have like yellow eyes, like yellowing of the eye, yellowing of the skin, like the terminology jaundice, right? Any unexplained weight gain or weight loss is also important. For the CNS system, we'll talk about presence of headache, any concern for seizures, so jerkings of arm and legs, mouth twitching, lip twitching, stuff like that. Neck pain and stiffness are very important to ask in the patient who present with fever, especially fever and a headache. It's very important for you to ask about neck and stiffness. For HEENT, so this HEENT stands for head, ear, eyes, nose, and throat, for those who doesn't know what that means. So I usually ask about sore throat, any kind of eye redness or discharge, any ear pain, pulling, discharge, any lymph nodes that they've been noticing, usually around the like neck area or like behind the ear. For respiratory, we'll ask about cough, any sputum coming out, what's the characteristic of the sputum, any breathing difficulty that they are noticing, any stridor, any wheezing. For the cardiac, we'll talk about chest pain, palpitations, syncope. Those are a little bit harder for younger patients, but it's for like school age group, it might be good for you to ask those questions. For GI, vomiting, diarrhea, decrease in intake, poor appetite, For GU system, as we kind of mentioned, decrease in wet diapers, painful urination is very important for like a little older kid who can describe things a little bit better. Urinary frequency or urgency, any genital discharge, especially in teenage populations. For MSK, musculoskeletal is what that stands for. Asking about body aches, joints pain, joint swelling. And then lastly, about the skin, like any new rash, any bumps, any lumps on their body that they're noticing. So generally, it takes about 5-6 minutes to run through this with patients, and it allows you to pick up a lot of important informations that might have missed, because a lot of time, like patient might not think that it is relevant until you ask them, and then they'll recall them and they'll answer you. So that is a very good thing for us to run through, and this is what kind of going to be the main point of practice for you guys today. All right. So, and then this is just a common cause of fever in children. This list is not at all extensive. It's like just the most common one. So I divided into the two groups, neonates and then children and teens. The reason why neonate has this entire group is just because they have a very different risk factor level, and they usually get exposure, a little bit of a different exposure to pathogen as compared to older children. So for neonate, the most common cause of fever in general is still going to be viral infections. But viral infection in neonate has more devastating consequences as compared to children and teens. So that's why we still kind of important for us to know about them. So common cold, those should be fine. RSV is one of the most common reasons to land a neonate or an infant in the hospital during winter months in the United States. Like sometimes, like in December, you will have the entire floor of the pediatric hospital with a patient with RSV. So that is very common. It can cause severe respiratory distress, and those patients need to be admitted. Flu and COVID is another common cause of viral infections for neonates. And then HSV is a very devastated viral infections. If it get picked up early on by neonate, it can cause disseminated HSV infections, and it actually can kill a patient within a day or two. So that's why it's important for you to kind of know about them. And then neonatal sepsis. So these are the bacteria infections that the baby picked up, not a lot from the environment, mostly from the mom, from the birth process itself. So it's a little bit of a different pathogens to it, but the general is bacteremia, so bacteria in the blood, bacteria in the urine, and then meningitis bacteria in the CSF. For children and teenagers, viral is still going to be the most common cause of fever. Some common bacterial infections that you're going to see a lot for children is going to be ear infections, group A's pharyngitis, pneumonia, UTI, sepsis, meningitis, and then for teenagers, sexual transmitted disease. So this is a kind of a good list for you to think about when you have a kid with fever. But remember, always have a little corner of your brain for zebra, because those can happen as well. All right. So this is my favorite part of being a pediatric resident, was taking mommy calls. I don't know if you guys have this in Vietnam, but so in America, every clinic will have a phone number where all of the moms, when they have concern off hour, can call in and talk to a physician on the phone and get advice, and then whether or not they need to go to the hospital. And then this is when your triage skill need to be top notch, right? Because you don't have the patient in front of you. The only thing you get is the history reported by mom. And most of the time, these happen at like in the middle of the night, 2 o'clock in the morning, and it's gonna be something that just out of the blue. So You can read the meme here. I'll read it for you just in case you don't see it. So, hi, Mrs. Moore. This is Dr. Hammerhorn. I just thought I would call you to see if Tippy's got hiccups again, like he had yesterday at this hours, and right now it's like 3 o'clock in the morning. We see this a lot. So sometimes like at night where there's no distractions, and this is usually when parents become concerned about random symptom that happens like a week ago that now they can remember and call you about. But let's say you are in charge of mommy calls today, and this is what you're gonna get. So this is the list of patients on the docket for you, and you have to decide whether or not these patients can wait for clinic tomorrow, or this patient need to go to the emergency room and see a physician right away. All right, so this is an interactive part. I want you guys to unmute and talk. So first one, 2-day-old with 1 hour fever. Emergency room or clinic tomorrow?
Emergency room.
All right, why emergency room?
Because he or she is a neonate, and fever in neonate is emergency.
Perfect, excellent. Any fever, doesn't matter how high it was, how long it was, a fever in a neonate immediately is a medical emergency. Perfect. All right, next one, a healthy 4-year-old with fever for 1 day.
Can wait for clinic.
Excellent. All right. Yeah. So, like, what do you think the kid have? What is the most likely cause of fever for this 4-year-old?
I think maybe the baby with fever most likely is viral infection.
Yep. So it's most likely viral. Like, so usually for this case, I will ask a couple more questions like any other, like URI symptoms, like cough, running nose, stuff like that. And even if they have a bacterial infections, as long as the kid is doing fine, it doesn't really need to go to the hospital right away. Sorry, let me making sure that I move things along. Perfect. All right, next one. 8-year-old with fever and a sore throat. All right, anyone else want to try? All right, I'm gonna start picking on people.
I think this belong to can wait for clinic.
All right, so what do you think that kid might have?
Yeah, I think the child may have the strep A pharyngitis.
Excellent. Yep, this is a Bram A script for group A strep. So usually I will making sure that the kid can still drink water. As long as he can still drink water, he can wait for me tomorrow in clinic. Perfect. All right, how about the next one? So pretty similar story. 8-year-old with fever, sore throat, and a stridor.
Emergency room.
Why? It's just stridor.
Because stridor is a sign of a respiratory failure, and maybe the child need oxygen support in hospital.
Excellent. So the only thing that I would change is that stridor is actually a sign concerning for upper airway obstruction, which is even worse than like just respiratory distress. So respiratory distress, I can support them with oxygens. If I'm really concerned that they have stridor, it means that their airway is closing up, or the sore throat might, the bacterial like pharyngitis might causing like pus, or it can be actually like bacterial tracheitis, and that's why the patient has stridor, and that might need actual intubation to keep the airway open. And those patients really need to be seen and be in a hospital setting. So excellent. All right. Next one, 18-year-old with fever and a headache.
Can wait for a clinic.
Yep. All right, can wait for clinic. What do you think he might have?
I guess it may be some symptom of a common cold.
Yep, it can be a cold, it can be a flu. So as long as he's otherwise healthy, can still drink, can still functions, can wait for clinic.
Yeah.
Perfect. All right. How about the next one? Same story, but he said that his neck hurt.
ER room, emergency room. because a neck stiffness it may be then similar with a symptom of infection with meningitis.
Yeah. So headache and the neck stiffness with a patient with fever is screaming meningitis. So even though it might still be a flu, it might still be a cold, I'm not taking chances with this one. This need to be going to the hospital. Perfect.
Yeah.
All right. Excellent. Thank you. Thank you for participating, guys. All right. You guys can go back to sleep now. All of the mommy calls are done. All righty. So as you notice, there's a like with all of the mommy calls, there's a lot of things that the presence of that simple phrase change the ways that you manage, and that's what we call red flags. And we'll talk about red flags next week. So stay tuned. For now, let's go practice some review of system. All right. Any questions before we head over into the breakout room? All right. I'll let Jay Helen take over then.
Terrific, thank you. Okay, I'm gonna share my screen. Okay, so this week we're going to try to stay in a guessing game show format, and when you're in your breakout rooms, then as a group, each person will have an opportunity to ask a question, and the group will have a total of 15 questions that they can ask, and the TAs will answer your questions only as yes or no, or something very simple like how old is the child. You can say 5 years old, but they might reveal that already at the beginning. And so at the end of 15 questions, I would like to invite everyone to talk amongst yourselves and discuss what the diagnosis is. And when you're ready, so after maybe a 5-minute discussion or so, you discuss it, what you think the diagnosis, and you will give the TA one answer, one team answer, and the TA will tell you if you're right or not.